So hello, this is Lori. I thought I'd go ahead and I like reading nurse practitioner books, study books. Being a professor and being in a profession where we're constantly learning, I thought, you know what? I have so many books. I probably have, I don't know, how many would you say I have, Becky?
Oh my gosh.
A lot of books. That's what I always use my CME. That's always what I use my CME for, typically, and so my CME money. So I like to read these different books. If you're in going to school to be a nurse practitioner, or if you're just thinking about that, I'm going to start reading. I mean, I read it, so I might as well, I do it for my own studying because it's kind of a lifelong study. But I'm going to be reading from this book here. This is a Family Nurse Practitioner, Volume 1, 5th edition, Nursing Certification Review Manual. I'm not in school. I teach in school, being a professor, and also just constantly I love to learn. I'm off for the summer. Been a nurse practitioner since 2010 is when I graduated. And so I've done a variety of different things, everything from, I've been teaching for years. I mean, I taught nursing students back in about 2008 or 2009, something like that. And then I went on to teach nurse practitioners up in Kansas City. And now I'm currently a professor at a major university in Missouri. And so I'm always learning. And so I suggest if you want to go, whether you're in nursing school right now or you're in nurse practitioner school, it's always great to just keep on learning and try to keep on growing. So what I'm going to do, and you guys don't have to do this with me, but I'm going to be reading anyways because I have a ton of books, and I figured, I'm just going to start reading, and I might even kind of cue you guys into anything that I see that I read that's a bunch of bleh, or if it's something that really should be highlighted, and so you'll see me. And I write in my books, and I highlight quite a bit, so we'll just go ahead and start on reading. So this chapter is about infectious disease. It says, making the correct diagnosis of infectious disease in family setting requires familiarity of the infectious organisms commonly seen in each age group. Mild illness in common children, particularly upper respiratory infections in infant and toddlers. And a fever is a temperature greater than 38 Celsius or 100.4 rectal. And I'll skip past that. I'll give you a little tidbit there. One of the places that I used to work, anything 99.1 and above Fahrenheit, it would flag us. The normal temperature varies throughout the circadian rhythm, being lowest in early morning and highest in the afternoon, which that makes sense. And a lot of patients also, I'm going to highlight that because I think that's important, using my granddaughter's marker. This is a big thing. The other big thing about temperatures in general is that a lot of elderly patients have lower temperatures, but they know for themselves kind of where they run. Even if it's a normal temperature to most, they still know where they run, and it may be just a lot lower than normal. So transmission of infection is influenced by the type of organism, its mode of transmission, and its viability in the environment, the number of organisms present in the environment, the resistance of the potential host to the organism, and the frequency of asymptomatic or carrier state. Something interesting to note about that is, there are some diseases where you get one and done. You think, or like you're unlikely to get again. Well, a lot of students ask me this question. They say, well, why do you not get something like measles or chickenpox? You could potentially, but something like chickenpox, there's not, the virus is more stable, whereas something like COVID, you're seeing different variants every year. It changes. Same thing with flu. So you'll see kind of that rapid turnover, and that's why we constantly need vaccines, where changing each year and catered to that specific variant or what they're seeing out there. So that's to answer that question. Antibiotic resistance is a growing concern. All providers need to ensure appropriate prescribing to prevent increasing resistance in community and populations. The biggest thing that I see as a provider is that a lot of patients, they think that every cold should be treated with antibiotic. So you have to do a lot of education still on this. I think that a lot more people in the last, I'd probably say maybe like 5 to 10 years, have gotten a lot better about understanding why antibiotics. There's so many different issues with antibiotics. And if someone uses an antibiotic before they really even need an antibiotic, let's say it's in a viral state and it hasn't progressed to anything secondary, like a secondary bacterial infection, if they start in the viral stage, when they shouldn't be on an antibiotic, a lot of times what can happen is if they do actually end up needing antibiotic, it won't work as well. We've also seen this in the case of, we used to give Z-Paks all the time for things like bacterial sinusitis. That just does not work anymore. I have a lot of patients, and I can tell the patients that haven't been in for a long time because they'll request a Z-Pak, and unfortunately that's not usually going to work in most communities. Some people it does help, but it's a great medicine for a lot of different things, including things like community-acquired pneumonia, and also things like if an individual has COPD and they get bronchitis, we do give them that. So there are a lot of good uses for certain medications that work very specific to that, but we have to be aware of different resistance and why and all of that. Evolving disease that are now drug resistant, such as gonorrhea and TB, are added to the concern. So I actually see more chlamydia, to be honest, than I do gonorrhea. This is in the Midwest, southern area, so I do see a lot more chlamydia than I do gonorrhea. Assessment. So once again, just if you're joining in, this is chapter 4 of this book here, Family Nurse Practitioner, Volume 1, 5th edition. I just like to read. I'm a professor, I'm a nurse practitioner, and we are in the profession of constantly learning. So whether you're a nurse or whatever medical professional type that you are, or nurse practitioner student, or a current nurse practitioner, I'm just reading what feels like hundreds of books that I have, and I thought I'd bring you guys along with me and give my little tidbits as I go along. Assessment. So an assessment of someone with infectious disease, you want to obtain a thorough history. Of course, we know that. What kind of questions do you think that you would ask somebody? And if anybody wants to comment, you can. What kind of questions, if someone came in with a fever, what are things that you think right away you want to ask them? Well, I know one of the things I want to ask them right away is I want to ask if they had any recent like trips, or if they had any recent antibiotics, or if they have any kind of rashes or joint pain. How high has their fever been? Have they ever had anything like this? Those are some great things to ask in your HPI. So, and then you want to also ask about possible contacts and exposure to infectious disease. It's very important to ask that question because a lot of times we make it, as providers, we make it a lot harder on ourselves than we really need to make it. So, we can just simply ask the patient, were you around someone that was sick? And a lot of times I'll get someone say no at first, and then somewhere I slip the question in again, and then they'll tell me, and all of a sudden they're like, oh yeah, this person had strep. Well, bingo, there you go. I mean, that is one great way to say, hey, I need this test and I need to do this. But it's not always that easy, but a lot of times it is. And so, and a lot of times what I'll ask patients, if a big thing with infectious disease is how long it's been going on for. Most things that people come in for related to infectious disease often are it's viral in nature. So keep that in mind. But if this is ongoing, and this is something like mono, there are other viruses that can last a long time too. But a lot of times it's just a viral illness, and some can last 2 to 3 weeks. So just be aware of that. Anytime a patient's getting worse though, or repeatedly coming in, that's always a problem. Just the biggest thing you want to know is when they're coming in, give them some kind of plan, because a lot of patients, as long as and especially write it down for them. Make sure it's in your charting, of course, but I like to write little to-do lists for them, and patients love that. I think that's something that over the years I've learned, that if you write a list for them, they will often follow that list. They're tired, they don't feel good, they're probably not going to read the paperwork you give them. Just be careful, anything that is in that little to-do list, scratch note that you give them, it needs to be in your plan, somewhere documented that you did give them that. So the other thing you're going to ask about assessment for like your HPI, so you're asking about exposure, contact. You're also going to ask if they smoke. Obviously, we know that smoking does increase the risk to develop a lot of different conditions, things like bronchitis and pneumonia and things like that. We also, this can key us into if someone has COPD. Over the years, that one of the things that I have learned is that, I can look at a patient and I can know whether or not they have COPD with their barrel chesting and their clubbing, and also, just the distinct characteristics of a patient who has COPD. So a lot of times that can key us into things as well. A lot of people are undiagnosed with COPD as well. Secondhand smoke exposure, because that's another thing that also can be a big risk factor, especially for little ones, for even things like ear infections. Immunization status, that's a huge one. So if someone comes in and they're saying, I don't vaccinate, and they're coming in, they got this chicken pox looking rash on their trunk, often viral exanthems will present on the trunk. And so if they're coming in with that, and they say, you ask that question, that really can help you to know if there's any further testing that needs to be done or what you're looking at. And also daycare attendance. We know that daycare is a big one. When, someone comes in and they're getting recurrent illnesses, often it is due to daycare attendance. And international travel history. There's lots of infectious disease. If you go on CDC, you can look at the yellow travel book or the yellow book, and that can kind of give you what countries, if you're traveling that country, what really, if there's any outbreaks or what vaccines are needed. I did a lot of travel medicine in the past, and you'll see quite a bit of patients coming in wanting to know what vaccines, if they're flying to, whatever, let's say they're flying somewhere to South America, they're going to want you to know where and what they need to get as far as vaccines, and what, if there's any issues that they should be concerned about and what to watch out for as well. So I'm going on to the next page here. So, and don't mind my nails. Sorry, my nails are I haven't painted them. This is just all at home. I'm still in my pajamas. It's summertime too. Let me adjust this just a little bit so you guys can see what I'm reading here now. All right. Okay, and hopefully you guys can see that. I have this on a, so I'm going to read this first part here. We're still on the infectious disease. Factors indicating possible bacterial infection includes loss of appetite, dehydration, high fever, chills, significant weakness, and or malaise. Perform a physical exam, evaluating for signs of infection, including vital signs, their skin, if there's any rashes especially, their eyes. A lot of times they'll have that conjunctival erythema or discharge, ears, nose, and throat, noting that if there's erythema and drainage in their nose, their neck, noting nuchal rigidity. And why would we want to do that? Can anybody comment? Why would we want to, if someone comes in with a fever and they've got a headache, why are we looking for nuchal rigidity? A lot of patients will actually have kind of like muscle stiffness when they have some kind of infectious process going on. But what are we looking for there for specifically? And I'll give you a hint. Let's just pretend that they also said that they had, this might give it away, but let's say they also have photophobia or light sensitivity. What are we thinking right away? Does anybody know? If you want to comment below, I'll give you guys just a second here. Meningitis, that's a big one. So, and then we could do the Brudzinski sign and Kernig's and see if that's what's going on there. We also want to look at their throat, noting any erythema or drainage. Also, if there's any exudates. Strep has a very distinctive look, but it's not always strep. A lot of times, mono and strep can look very similar. And then their lungs, noting if it's dull, diminished, or adventitious lung sounds. Heart, noting any kind of murmurs or rubs. Rheumatic fever, things like that. And then abdomen, noting any kind of tenderness, changes in bowel sounds, organomegaly. Organomegaly specifically for something like specifically something for like mono. I've had patients in the past who came in with just abdominal pain, and we found out that it was mono. So that varies sometimes. It can be right side because you can have elevated liver enzymes also from mono as well. So, and also musculoskeletal exam. You want to note tenderness, warmth, edema, erythema. Neurological exam, including mental status exam, especially elderly patients. You're going to see elderly patients if they get an infectious process going on, a lot of times they will be very confused or just not quite with it. The other thing you have to worry about, obviously, is sepsis. That is one of the indications that, hey, they may be septic here, especially if you're seeing the vital signs all over the board. They're hypertensive, they're tachycardic, they've got a high fever. So that would definitely be flagging for, hey, they probably need to be in the hospital. So you want to make sure that the neurological exam is done for that reason. That's why we do it. A lot of times people don't think about that when they're just trying to look at an infectious process, like someone comes in with a cold. This is really important. So you also want to make sure if there's any kind of central nervous system infection, encephalitis, things like that. So rapid testing for strep, mono and flu, and COVID. This book was 2019. So obviously there wasn't a lot of probably things about COVID at this time, although, the coronavirus family has been around forever. But this is something that I would add to this list as well. There's also new RSV rapid testing as well that we have in a lot of the clinics. I worked in one where I basically felt like every single type of rapid test. I even had the adenovirus test for viral conjunctivitis, which is pretty cool, by the way, but it wasn't a very accurate test, I feel like. And I saw more false positives, I think, than false negatives rather than false positives. It was just really, you had to get a lot of the drainage from the lower conjunctival sac onto the little swab. So that is something you may see. All right, so where are we? And then initial screening to determine the best approach and course of treatment. Sometimes you may have to do throat cultures, things like that as well. Rapid test, if they had any antibiotics in the last couple months, a lot of times those rapid tests, you'll get a false negative. You want to obtain, well, there we go on to the next one. Obtain a culture to determine causative organisms before treatment to prevent false negative results. So I guess the other thing that is important to understand is sometimes we forget this. When a young patient is coming in, or any patient that it's the middle of the summertime, there's not a lot of colds going around, you need to be aware of any kind of STIs or sexually transmitted infections in the throat area. So that's something I think it's important that is often missed, and you would use throat culture for that as well. Sensitivity testing helps clarify the most appropriate antibiotics to use, and that's very helpful. All right, so management of infectious disease. So let's talk about, and this is just a general overview. So this book's kind of I really like this book. I like the smaller books for some reason. Like, well, I shouldn't say smaller, kind of like the mid-sized books. So this is kind of one of them. I don't know why. I get those books are my books. All right, so management infectious disease, assess for allergies to medications and clarify type of reaction to previous antibiotic use. So there's a lot of people who think that they have penicillin allergy, and they actually don't. But this can become quite tricky. If someone had anaphylaxis, I wouldn't want to ever be even trying. There's testing that they can do specific to penicillin allergies. So you might want to get someone who, if they have a ton of allergies to different types of antibiotics, you might want to have them actually sent to an allergist just to confirm that, because once you're ruling out, the penicillin group, you're kind of ruling out quite a bit. So, and then also things like the cephalosporins, there is a small crossover. They're kind of like, depending on what generation, for potential, if you're allergic to the penicillin group, that you might be potentially also allergic to cephalosporins. Be aware of drug-resistant patterns in the community. That's a big one. Avoid treating a viral illness with an antibiotic just in case, or because the patient or parent insist on one. Improvement with the antibiotic usually occurs 2 to 3 days from most infections. I often tell most parents, most people in general, that days 3 through 5 for most viruses are going to be the worst days, and then they should be feeling somewhat better days 7 through 10, and that they can either call me back if they're getting worse after that, or obviously any kind of emergent things that are going on, they need to call me before then. But make sure that you tell the patient what to call. So if they're having a fever of like 104.5, you probably want to have them call you, or I probably would, depending on what's going on. I mean, I might have them already go to the ER, especially if they're acting lethargic and they can't keep food down, or they're vomiting, whatever's going on. It's all, you have to take it all into consideration, but definitely I would probably be saying, hey, you need to be seen by a higher level of care. It's important to educate the patients and document the criteria for reevaluation if patient's not improving. I already went straight to that. So I will give them specifics. If you just tell the patient something like in your plan section or education section, if you specifically just tell them, hey, just come in if you don't feel good. That's really patients, you got to remember, when they're not feeling well, they're not hearing a lot of what you say. So if you have that little to-do list for them, you might want to jot like what temperature or what symptom might they want to be seen again for. So let's say if their throat's getting worse and their fever's getting higher, if their throat pain is getting worse and their fever is not resolving under whatever degree, or if it's staying above whatever degree, you might want to document that. But also let patients know that obviously if they're taking antipyretics, like things like acetaminophen or any kind of NSAIDs, things like that, then they may not even have a fever. So that might be suppressing it. So 90% of all respiratory infections are viral. I've seen different percentages on that. I think that depends on the time, but and that's why we don't treat things like bronchitis with antibiotics unless you have COPD or other concerning conditions. To avoid the risk of patient developing Reye syndrome, do not prescribe or administer aspirin or products containing aspirin for viral infections to younger patients than 19 years old. So that's pretty straightforward. You might see that on a test somewhere, whether a nursing school or a nurse practitioner or a PA, or if you're a medical student, you will likely say something about that. Due to decreased immune response, older adults have an increased risk for secondary bacterial infection. So these are patients that you probably want to have a call back in if they come to your office, or you might be a little bit more lenient as far as if you want to give them an antibiotic. And a lot of times what I'll do is if I'm concerned about a patient and I give them some things to do and they go home and they do it, I give them a call back. Now I know that's not realistic in every setting, but I do give them a call back if I'm really concerned about them, and I check on them and see how they're doing. Most of the time they're like, yeah, I'm doing better. But at that time, that's a great time for them to be able to ask questions as well, and I document that. If the patient is pregnant, use antibiotics in pregnancy category B, and be aware that most antibiotics pass into the breast milk. So if they have a lactation consultant, that's always very helpful. No local health department guidelines for communicable diseases. This COVID was a big thing for that. Obviously, we were sending reports regularly to them. Seek referrals to infectious disease specialists earlier rather than later in the course of unusual infection. This is important because, I remember one of the first patients that was asking me, and this was before it was like, December is when we were kind of hearing a lot more about COVID, and then when it all started. But November is when I started actually having patients ask me some questions, and we all didn't know at that time. We thought, this is a virus, this will pass. But boy, it took a long time for it to really get to the point where, we even walk around without masks, and I still see people with masks as well. So it's definitely something that if you have questions, don't be afraid to ask. So you might want to become familiar with even things that are out there like Zika virus, or even what Ebola, what kinds of things you see. It's just important to be aware of that. And then of course our infectious disease that we don't see as much because of vaccines. So like measles, mumps, pertussis, things like that. So make sure, I would definitely say to learn about those things and what they look like. And anytime someone's just not getting better or they're progressively declining, they do need a higher level of care. So be alert to endemic diseases, be alert to diseases that may result of international travel or bioterrorism. So it's a big one. So that's why we ask patients all the time. We always say, hey, have you been traveling recently? And that's why they also, when people travel, they get their vaccines before they go a lot of times and make sure everything's up to date. So hopefully you guys can see the top part. So I'm moving on. So for those of you that might be joining in, I'm on Chapter 4, Infectious Disease. This is a Nurse Practitioner, Family Nurse Practitioner, Volume 1, 5th edition. It's actually a certification review book. I am a professor and I just like reading all the time. And so I like reading the certification, and I like looking at different sources. I never look at just one source. Obviously, things change. And so I like to look at lots of different things and also get ideas for my students. So red flags, infectious disease red flags. The very young and the very old are special risk for severe infections, as are those with compromised immune systems, such as people with history of splenectomy or illnesses such as diabetes. That's a big one. You also want to I think this is something, and this is just real life. I'm giving you guys some real life tidbits, and you guys can add any if you have any as well. But if you're a practitioner or a nurse and you're a nurse on the floor and you see certain things, I love hearing what you guys, of course, HIPAA, make sure no patient identifiers, but, I love hearing what you guys have to say also about what you've seen from your experience. I think as a community in healthcare and we're always evolving and we're always learning, I think it's important for us to share our experiences in a very HIPAA safe way. So I guess I should say it like that. So things like Rocky Mountain spotted fever, usually kiddos under 5, those are going to be the ones that are going to be, they're going to have issues the most, or those who are immunocompromised or elderly. So this is important to understand that you really need to keep a close watch on these individuals. And then anybody who has diabetes, usually what I will do if someone has diabetes and they have some kind of, infectious process going on, or whatever's viral illness or whatnot, I always ask them what their sugars have been running. Now, a lot of diabetics, they do not, or people who have diabetes, they do not take their sugars, type 2, and so that's just, they may be on a medicine, their blood sugars may not be that bad, and so you just may have to find out, number one, if they do have a monitor, and if they know how to use it, and if they can start using it. And then also, you need to take one in the office as well. And I say you need to, but whoever you have, an MA or whatnot, you need to make sure to document that, because when you're sick and if you're not drinking a lot, you're dehydrated, you're more likely to have an elevated glucose, and that's important to understand. And you may have to actually kind of titrate some medications. So that's important to understand. Recognize the unique physiological and psychological responses of older patients to infectious disease and therapy. A fever with listlessness or flaccidity requires an aggressive evaluation no matter the patient's age. That's important because dehydration is a big deal, especially in little kiddos. Kiddos under 5, often they can get, because of a fever, vomiting, not eating, not drinking. You need to be making sure that they're going to the bathroom. These are the ones that are often getting dehydrated very quickly. And then the elderly, often they don't catch their sign. They're not sometimes it takes a lot longer for them to pick up on their signs and symptoms. And I mean, I have had patients that have had pneumonia for probably 2 weeks and didn't even say anything to their families until, like a day before they came into the hospital and had to admit them to ICU. So bacteremia and sepsis may present with fever or hypothermia, chills, tachycardia, tachypnea, hypotension, or altered mental status. As I mentioned earlier, mortality is nearly 50% in septic shock. This is something that can happen in a matter of hours, so we need to make sure we get this. Bacteremia can also present in sepsis as well, in the form of a kind of a macular papular rash all over the body. I've seen that before. Consult or refer to a specialist, and in this case it'd be infectious disease if the illness does not respond to initial therapy or present in an unusual manner. Hospitalization may be necessary if the patient is unable to take oral medications or maintain hydration, or has a severe infection requiring IV antibiotics. So, obviously you're going to be doing blood cultures, and you want to get those blood cultures done before you actually start them on antibiotics. It doesn't always work out that way, but ideally that's what you want to do. And then most hospitals, in fact, I don't know a hospital that wouldn't, but most hospitals, if not every single hospital, should have some kind of protocol or sepsis guideline or criteria of like what dings when you need to say, hey, I need to call a physician or nurse practitioner, PA, or whoever's on call, and say, hey, this person's dinging for, they got the service criteria, or they're dinging for sepsis and severe sepsis, and what do we need to do next? Getting them started on aggressive fluids, if indicated, antibiotics, start watching their vital signs more often, all of that. And so that is something that definitely if you are not familiar, definitely be familiar with the sepsis protocol. And so infectious disease, usually too, a lot of times they'll be involved in it, especially if things are not going in the right direction. Know and recognize common diagnostic features of certain illnesses, such as Koplik spots, so measles, they're in the mouth. I've seen them maybe once or twice in my career, but you're not going to typically see something like that. I've seen things that I thought maybe were that, but with the way that vaccines have helped so much with reducing infections like measles, we don't see that as much. That's not something typically, but you do need to be aware because there are outbreaks. Subcutaneous nodules and rheumatic fever, etc. Educate the patient, caregivers, document recommendations, and follow up with the patient and caregivers when an infection is not resolving as expected. One of the things that I want to just mention about that just real quick here is that when you have a patient who has strep, they tell them to throw out their toothbrush 24 hours after using an antibiotic or taking the antibiotic. And also other things like if they have mouth guards, they may have to disinfect them a certain way. So, if they have... Also, if they have retainers or things like that, or even I had one patient that kept on getting recurrent strep, and it was actually their lip gloss, and so is what we end up finding out. So that's kind of a strange thing, but you don't normally see that, but that was the only thing that we could figure out maybe that was causing the recurrent infection. Also, making sure that the partners are treated and such. So this is definitely something that you want to document. I've had patients that we'll try to say that some things weren't done. But if you actually document that, there's a lot of smart phrases that you can use where it will just auto-populate. I like to type in these things and maybe give specific personal things to them, and then put that the patient's parent understood or the patient understood, because then that gives very specific to show that you actually went over that, versus sometimes smart phrases are really just kind of generic and one size fits all, and it doesn't always, it just looks generic a lot of times. All right, moving on. So now that we're still on the infectious disease, kind of going along, reading through here, this NP book here, talking about some infectious disease and reading it with you. This is what I normally do a lot when I'm coming up with test questions and just studying in general. That's something I think we should all be doing to some extent as providers, especially with just trying to continually learn and educate ourselves. But I do it also for the purpose of I am a professor and I like to educate. I think it's something that I'll always have, it will always be near and dear in my heart. So moving on to pediatric issues. Any infant with a fever who is younger than 4 weeks of age or 1 to 3 months of age with fever and no focal signs of infection may require admission with a workup, including urine and blood cultures, lumbar puncture, and chest x-ray. And a big thing with this too is a lot of times these little ones, because they do get dehydrated so quickly, this is not my specialty. I do see kiddos, but not super young kiddos. But they can get dehydrated and they can decline very, very fast. And so the other thing is too, they're not going to tell you. They babble. They say a few words not at 1 to 3 months, but after 1 year old, or even like when they're getting a little bit older, they may say just a few words and not make quite sense. My granddaughter, she's 3, and we get most of what she says, but every now and then we don't know what she's saying. So, but yeah, they can't really tell you exactly what's going on. They can't tell you if they have a headache. Sometimes we can see signs of if they are not eating, if they're drooling, that can give us a sign that maybe the throat hurts, or if they're pulling at their ear often, that can be another sign as well. If they're teething, a lot of times they'll have that drooling as well. Frequent up to 10 viral illnesses, especially upper respiratory infections per year, are common in infants and toddlers, especially if they go to daycare. You may even see more than that. To avert the risk of Reyes syndrome, the family nurse practitioner should educate the caregiver of children between newborn to 19 years of age, educate adolescents to avoid over-the-counter medications and other products that contain salicylates and other related compounds. So aspirin, anything that has aspirin in it. Transmission of infections in older infants and toddlers is mainly through droplet secretions on hands and sharing toys in group settings. Once again, daycare. Children are contagious long before they are symptomatic. That's a big point there. I think that's if you are studying for any kind of test, often that is a big thing that we'll see. While it is important to exclude sick children from group settings and contact with other children, parents and daycare need to understand that they will not necessarily reduce the spread of infection of others. Good hand washing is the single most effective tool to prevent illness. Hallelujah. Let me star that one. That is absolutely the case. And also, covering coughs and that's a big one too. In the crook of your elbow or your arm. Washing toys may prevent the spread of illness. Some people ask me what I like as far as cleaning. Always a bleach solution is a good idea, but you can also I like Lysol sprays. I know when I was in a I worked in a retail clinic, and it's a very enclosed small space. And I noticed when I would get back-to-back sick people, I would use that Lysol spray, have my mask on. I don't know what made the difference. It just felt like I don't know. That malaise feeling sometimes you get with being around sick people. It seemed like that just sprinkled the dust away. It didn't take care of it always, but it definitely did. So, moving on to the next, and this is in the 4th chapter, infectious disease. So where are we here? Okay. So 2012 Child Care exclusion list. And let me see if I'm going to jump past this. So I haven't read this book before. So this applies to all children out of home childcare, all students in 3rd, 4th, 3, 4, 5. I'm seeing what it says here. Medically fragile students in first. What is this saying here? Not sure what this is, so I might skip past this. But let's jump. Oh, I saw. Oh my goodness. I'm still waking up. 2012 child care exclusion list. So what this sounds like this is saying is that you guys tell me what you think this says. I think I know what it says, but before I say, I'm just going to jump on to the next section here. Varicella. Children with chickenpox may return to daycare or school with a parent note once all of the sores and blisters are dried out or scabbed over, if there are no scabs, until no new sores appear. And then diarrhea. For most kinds of diarrhea identified as 3 or more loose stools in 24 hours, students in 1st through 5th grade should stay home until diarrhea stops or until doctor clears the child to return to school. A lot of times, viral exanthems, once the fever is resolved, you're often okay to go back. If it's been at least 24 hours and there's no fever-reducing medications, often you may get a rash pop up, though, and that scares a lot of patients, and they may be long past their infectious, or at least some points past their infectious process, and they are not. But some, obviously viral shedding is something big to think about too, because that can be ongoing for some time. But the longer you go from the initial fever and symptoms, and the majority of the symptoms, a lot of times less contagious that the individual is. So let's see. I think I'm going to go past this. So I think what this is basically saying is just basically like return to school notes. Overall, there are some things. It's got Shigella and Campylobacter here, Salmonella. I don't think I'm going to get into this too much, because it says kind of basically, okay, when should you send them back? I don't know if this is something, if you are studying for an examination, I don't know if this is something that you're going to see on there, because that kind of varies from clinic to clinic, but there's an overall, thought process that if they have a fever, should be fever-free for at least 24 hours without fever-reducing medicines. So I'll just go on to this here. I'm just trying to look here. Actually, I'm going to scan here and just see if there's anything in particular that I want to tell you guys specific to this. Fever by itself, infants less than 4 months old, keep them home for rectal temperatures of 101 or higher. Children over 4 months old, keep the child home for a fever of 101 or higher by the mouth, 100 or higher if taken under the arm, and 102 or higher if taken in rectum. And children can return with the parent note when fever is resolved. And head lice. Let's talk about that one, because I think that's an important one. This is one I get asked a lot of. Head lice. Children with crawling lice or nits, so the eggs, 1/4 inch or closer to the scalp may be sent home at the end of the day if head-to-head contact with other children can be avoided. Otherwise, they need to be excluded immediately. A child may return with a parent note after his or her first treatment with a school-approved lice removal product. If there are no active lice crawling on the child's head, the school or the center should check the child 7 days after treatment for newly hatched crawling lice. If any are present, the child will have to be retreated for lice to return to school or childcare. So I think this is an important one. I'm going to just highlight this section here, because you'll get that question asked a lot. Your clinic may tell you to say a little bit something different, or they may recommend something a little bit different, but I think this is pretty good recommendations overall. Sometimes, we don't want kids to miss school, but sometimes I'll ask the parent to kind of just maybe check a day or two to make sure they're not seeing stuff crawl around, and then also making sure that they're treating items in the home too. But that 7-day mark is really, really important. All right, I'm just going to go past these because these are not ones that we're going to see a ton. Although scabies, let's go to this one here. Children with scabies should be out of school until treatment medication has been applied. A medical note is required to return. An important thing to know about scabies is that these individuals, even after being treated their one-time treatment, they may have to be treated again. They may have itching for up to 4 weeks. I've seen this. I've had people that come back in, but it's usually significantly reduced. And typically scabies is not going to affect above the neck. So they don't typically need to treat their head, unless obviously they had lice as well. But they usually treat from their neck down, all over their body, and they need to make sure they're putting any kind of jewelry that they've been using. I always tell them to do like in Ziploc bags, and then any kind of like stuff you want to wash and rushing hot water. So it's kind of a pain in the what to have to go through this. So I really feel bad for any individuals, and they feel mortified. Most individuals who have scabies, they just feel terrible. They are embarrassed, and making sure that you are there in a very supportive way. Obviously, you have to protect yourself too, but even doing things like letting them know about that they may still have itching, and that, hey, at 7 days, let's see where things are. A lot of these patients, I will call them back to kind of see how things went as far as the treatment, how they're doing. I had one individual that came back, and she just almost about started crying, and because she was incorrectly diagnosed. And so she was so happy after I told her exactly what to do, and I followed up with her. She ended up being, as long as I was at this place, she would come in and be like, ask all the practitioners where I was, because sometimes I would float around to other places, and she'd drive to wherever I was. So that was kind of, I don't know, that was definitely a nice thing to hear, and I felt good about it. I just felt really bad for her. Strep throat. So a child with strep can return to school with a medical note 24 hours after starting antibiotics, as long as there's no fever. And I usually will tell them a little tidbit in there, something too, as long as they're starting to feel better. So if they need an extra day or so. So those are the main ones. I'm going to go past these. Oh, well, maybe the vomiting. Let's do that. Sorry, guys. I keep on tricking you here. I'm just kind of scanning through here. And sometimes I'll do this with books too. If I'm like, well, I need to read up on that, then I'll go to that section. In fact, I just noticed one. This is probably the one that you will get asked the most questions besides scabies, conjunctivitis. When do I return? So I'm going to read this here. Children whose eyes are red or pink and who have eye pain and reddened eyelids with white or yellow eye discharge or eyelid matted after sleep should not return to school until they have been examined and treated. A medical note required to return. So if you are absolutely convinced that they have bacterial conjunctivitis, you're going to have a lot of grittiness with that. They often get their super matted eyelashes, and they can't open their lids. A lot of times it's on one side and then can go to the other one. Once you get them started on the antibiotic, they usually, because they have to do it several times a day, depending on which one you use, the eye drops, they often start getting better very quickly. So that's a nice thing about it. Now, if they have viral conjunctivitis, which, by the way, adenovirus is the number one virus that causes that, that is a pain, because these are often the patients that will call you back up in 4 days and say, it's still not better. It's not better. And this is why we do not want to assume that every single, in quotes, pink eye is always the bacterial kind. So viral conjunctivitis is something that it can last 7 to 10 days, extremely contagious. And so that really just is a tricky one, because, you really don't want them to go back right away, because they're going to spread it to the rest of their class. I might do a video on this one specifically, because I looked up previously what the exact recommendations, and it kind of was a little bit, it was as clear about as mud. So it was one of those things where it was kind of saying, well, as long as they're getting better and it's almost been a week. And then I saw something different. So, lubricating drops is the biggest thing with that they're going to be using. And so a lot of times the lubricating drops really do help significantly. But maybe I'll do a video on that. Give this a like if you want a video on viral conjunctivitis, and maybe I'll do that. All right, and then moving over here, so vomiting. A child who has vomited 2 or more times in 24 hours should stay home until the vomiting stops, unless the child is known to be contagious. All right, well, I think I've been on for a little bit and reading. I think that I've had enough reading for right now. Hopefully this helps. I definitely will start doing this on a regular basis. I might even put a time down. That's really hard to do, though, because there's not a time. If I start scheduling the time that I'm going to read, then I won't want to do it. So I definitely want to, if you guys like this type of format, if this helps you, if you're studying to be a nurse practitioner, or even if you're studying to be in any kind of schooling related to medical, any medical, I try to give my experience. Like I said, I'm a professor. I've been a nurse practitioner since 2010. I've worked in a variety of settings. My favorite one was probably when I worked with the hospitalist group. I was an NP hospitalist, and I loved loved it. So I learned a lot there, but I mean, I've worked in so many different settings, and I've been a nurse since 2007. And then I had a degree before that in social psychology. So I really like sharing what I learned. I've always found that it really does help me to share things, and I am never stopping learning. I am never stopping learning. It sounds funny to say it like that, but I do not stop learning. I like to hear new things, and I like to see new things. I like to get you guys' input. And then let me see real quick here. Triage, RN, family medicine. So this is super awesome. Good. Well, thank you, Brandy. I'm glad that makes my day. That makes me happy to read that. And I'm sorry if I missed anybody's comments. My phone's set up weird, so I can't really see the comments too well. But I'll do this. And if you guys have experience in what you do, let me know too if you see things, because I really am really big about telling my students that, hey, you know what, you know a lot of things that a lot of people have no idea about because of your expertise, what you do on a daily basis. So I always love sharing. I always love sharing even my students with their experiences, and I learn a lot of great things from them. So yeah, absolutely. Well, I will be on here at some time later. I don't know when. Maybe I'll make it a daily